Welcome back to the Deep Dive. Today we're tackling something truly incredible, that immediate, intense biological transformation when a fetus becomes a newborn.
It's more than just birth, isn't it? It's like a whole system reboot happening incredibly fast. We've looked at sources covering these first critical hours, the huge shifts in breathing, circulation, and keeping everything balanced like temperature and blood sugar.
Right. Let's dive straight into that moment right after delivery. The sources really stress immediate stimulation. Why is that so vital?
Well, the baby comes out wet, often into a much cooler environment, and they basically need jolt to start breathing independently. So that vigorous drawing, maybe some gentle suctioning, it's not just about cleaning, it's critical sensory input.
Life-saving input, essentially. And that leads straight into the APGAR score, right? First check at 1 minute.
Exactly. 1 minute, then again at 5 minutes. People hear APGAR, but it's the score itself that tells the story. We're looking for scores above 7, ideally.
Okay, above 7. What does a lower score signal? What's going wrong if it's, say, a 5?
A score below 7 means the baby's having significant trouble transitioning. Maybe the heart rate's low, or the breathing effort isn't there, poor muscle tone. Those immediate steps, the drying and stimulating, are partly aimed at boosting those APGAR components and hitting triggers for that crucial first breath.
Okay, so let's unpack the triggers for breathing.
Yeah.
It's like a perfect storm of signals hitting the baby all at once.
Pretty much. You've got chemical triggers. The oxygen level naturally dips during the final squeeze of labor. Then there's the thermal shock, going from maybe 98.6 degrees Fahrenheit in the womb down to room temperature.
Which can be a huge drop.
A huge drop. And then, like we said, the sensory stuff being touched, dried, handled, it all tells the brain, time to breathe.
And physically, that first breath is a massive effort, isn't it? The lungs are full of fluid.
Exactly. All the amniotic fluid has to get squeezed out or absorbed, and air has to rush in to replace it. This establishes what we call functional residual capacity, or FRC.
FRC. Remind us what that is, and why is crying so important for it.
FRC is the air left in the lungs after you exhale. It keeps the tiny air sacs, the alveoli, from collapsing completely. Crying is like a super powerful exhale against resistance. It generates really high pressure that physically forces those airways open and establishes that baseline inflation. It's hard work.
Like blowing up a really stiff balloon for the first time.
That's a great analogy. And what helps keep that balloon inflated, makes it easier to breathe ongoing, is surfactant.
Ah, the lubricant for the lungs.
Precisely. It's a substance that coats the alveoli and reduces surface tension. Without enough surfactant, the lungs are stiff, non-compliant, and every breath takes enormous effort. That's the core issue in respiratory distress syndrome, which we'll get to.
Okay, so the lungs inflate, air comes in. And this triggers a cascade in the circulatory system, like a domino effect.
A massive one. As the lungs expand, the resistance in the blood vessels within the lungs just plummets. Suddenly, it's much easier for blood to flow to the lungs than to bypass them.
Which he was doing in the womb, using those fetal shunts.
Right. So the blood flow redirects. It rushes to the lungs to pick up oxygen. This pressure shift is the cue for those fetal bypasses, the shunts, to start closing down. They're not needed anymore.
And there are 3 main ones to close.
Yep. The foramen oval, that little flap door between the heart's upper chambers, usually functionally closes pretty fast within an hour or two just from the pressure change. The ductus arteriosus, connecting the aorta and pulmonary artery, takes a bit longer, maybe functionally closed around 18 hours or so. And then the ductus venosus, which bypassed the liver.
With all this dramatic replumbing happening, it makes sense the vital signs would be a bit wild initially.
Oh, absolutely. The heart rate can shoot up to 180 beats per minute, right at first like they just ran a sprint. Then it usually settles into the normal newborn range of 120 to 160. And because blood flow patterns are changing, hearing a temporary or transient heart murmur is really common and usually not a concern unless it sticks around.
Okay, breathing established, circulation rerouted. Now the baby has to deal with the outside world. And the next big challenge is temperature, right? They get cold so easily.
Dangerously easily. It's partly just physics. They have a huge surface area compared to their small body mass, so heat radiates off them quickly. Plus, they don't have much insulating fat yet.
And they can't shiver effectively like adults do.
Not really. Their main way to generate heat is by burning a special type of fat called brown fat, but they only have a limited supply, and burning it uses up a lot of energy and oxygen.
So getting cold isn't just uncomfortable, it's metabolically dangerous.
It's a rapid downward spiral. We call it cold stress.
Yeah.
To make heat without shivering, the baby burns through oxygen and glucose incredibly fast. This can quickly lead to low oxygen levels, low blood sugar, and metabolic acidosis.
And you mentioned 4 ways they lose heat. Can you give us quick examples? Like, how does it happen in the delivery room?
Sure. Evaporation is the big one. Right at birth, they're covered in amniotic fluid, and as it evaporates, it cools them down fast. That's why drying is step one. Conduction is losing heat to a colder surface they're touching, like putting a naked baby on a cool metal scale.
Right.
Convection is heat loss to moving air, like a draft from an open door or an AC vent blowing nearby.
Okay, makes sense.
And radiation is losing heat to cooler objects nearby, even without touching them. Think of placing a baby bassinet next to a cold window pane.
Got it. So preventing all that is key to maintaining a neutral thermal environment, or
Mhm.
NTE.
Exactly. NTE is the temperature range where the baby uses the least amount of energy and oxygen just to stay warm. The best way to achieve that initially, skin-to-skin contact with a parent. It's simple, effective, uses the parent's heat.
And standard nursing care follows from that.
Yep. Dry them immediately and thoroughly, maybe put them under a radiant warmer, often just in a diaper to maximize exposure to the heat. Pop a little cap on their head because a lot of heat is lost there. And if their temp does drop below about 36.1 Celsius, we need to rewarm them slowly and carefully.
This leads us neatly into something you called the neonatal metabolic triangle.
Yeah.
Sounds like the core vulnerability here.
It really is. It connects hypothermia, low temperature, hypoxia, low oxygen, and hypoglycemia, low blood sugar. The critical thing to understand is they cause each other. It's a vicious cycle.
How does that work? Walk us through it.
Okay, so if the baby gets cold, hypothermia, they start burning that brown fat, which consumes massive amounts of oxygen and glucose. So boom, you risk hypoxia and hypoglycemia right there.
And if they're already having trouble breathing, say, hypoxia.
Then their cells can't use glucose efficiently for energy, leading to lactic acid buildup, making acidosis worse. And the stress itself can deplete glucose stores. So any problem in one corner puts stress on the other too.
It all feeds back on itself.
Precisely. That's why constantly monitoring temperature, breathing effort, and blood glucose is so fundamental. They're intertwined. And things like infection or sepsis can throw all three at a whack simultaneously.
Okay, let's zero in on the glucose part, hypoglycemia. The sources define it as below 40 milli-GDL. Who's most likely to have this issue?
Any baby under significant stress. So infants of diabetic mothers are classic examples. Also, premature babies, babies who got cold stressed, babies born small for their gestational age, SGA, or even large for gestational age, LGA. Basically, anyone whose energy demands might outstrip their supply or ability to regulate sugar.
And how do we fix low blood sugar quickly?
First line is always feed the baby if they can safely eat. Get some calories in. If that doesn't work or isn't enough, 40% oral dextrose gel is often the next step. It's simple, non-invasive, and studies show it really helps keep babies out of the NICU just for low sugar.
And if they can't take anything orally?
Then it's IV fluids, typically with 10% dextrose, to provide glucose directly into the bloodstream.
All right, let's shift gears to the liver. It suddenly has a huge waste processing job, right? Dealing with bilirubin. Can you break down the two types?
Sure. You start with unconjugated bilirubin, sometimes called indirect. This is the byproduct of breaking down old red blood cells, something that happens a lot right after birth as fetal hemoglobin is replaced. This type is fat-soluble, which means it can cross the blood-brain barrier and be toxic if levels get too high.
That's the dangerous one.
That's the one we worry about. The liver's job is to take that unconjugated bilirubin and chemically change it, or conjugate it, into conjugated or direct bilirubin. This form is water-soluble, non-toxic, and the body can get rid of it in urine and stool.
Yeah, and it's super common for newborns to get a bit yellow physiologic jaundice. Why does that happen in, 85% of babies?
Mostly because the newborn liver is still immature. The enzymes needed for conjugation just aren't fully up to speed yet, so there's a temporary backlog.
Makes sense.
Yeah.
But other things can make it worse.
Definitely. Anything that increases the breakdown of red blood cells adds to the bilirubin load. Think significant bruising from delivery,
But
or a cephalohematoma, which is a collection of blood under the scalp. But a really big factor is delayed stooling.
why does not pooping make jaundice worse?
Because the conjugated bilirubin, the safe kind, gets excreted into the gut. If it sits there too long because the baby isn't stooling, an enzyme in the gut called beta-glucuronidase can actually unconjugate it, turning it back into the toxic fat-soluble form.
No way.
Yep. Then it gets reabsorbed back into the bloodstream, adding to the problem. This is why delayed feeding, or sometimes even exclusive breastfeeding initially if milk supply is low, can contribute because it delays meconium passage.
Wow. Okay, before we talk treatment, the sources mention vitamin K injection. How does that connect to the liver?
It's crucial. Newborns don't have the gut bacteria yet to make their own vitamin K, which the liver needs to produce essential blood clotting factors. So we give a vitamin K shot routinely right after birth to prevent potentially serious bleeding while the baby system gets going. It's a safety net.
Got it. Okay, so if bilirubin levels climb too high, the main treatment is phototherapy. What are the key things nurses need to do to make that work effectively?
Right. Phototherapy uses specific light wavelengths to change the unconjugated bilirubin in the skin into a form that can be excreted without needing the liver. So, number one, maximize skin exposure. The baby needs to be undressed, usually just a diaper.
Okay, nearly naked under the lights.
Exactly. Number two, eye protection is mandatory. Special patches or shields must cover the baby's eyes because the light can damage their retinas.
Crucial.
Then, positioning. The lights need to be close, usually within about 30 centimeters, to be effective. And you need to reposition the baby regularly, like every couple of hours, so different areas of skin get exposed.
Makes sense, like getting an even tan, but for bilirubin.
Kind of. We also try to cluster care, do all the necessary things like feeding, diaper changes, taking vitals all at once so the baby spends the maximum possible time under the lights uninterrupted.
And monitoring is still key.
Absolutely. Check temperature frequently, maybe every 4 hours, because the lights can make them too hot, or, paradoxically, sometimes they get cool. Hydration is also vital. Encourage fluids, track urine output carefully, weigh diapers. Loose greenish stools are actually a good sign. It means the bilirubin is being excreted. Oh, and one procedural point. Turn the lights off when drawing blood to check bilirubin levels. Otherwise, it can affect the sample.
Now, not every baby starts this transition journey equally equipped. Size matters, right? Let's start with small for gestational age, SGA babies below the 10th percentile weight.
Right. These babies often look a bit skinny, less chubby, maybe less muscle tone. They've often experienced some kind of growth restriction in the womb, maybe due to issues like maternal smoking or high blood pressure affecting the placenta.
And their risks are amplified versions of the standard challenges.
Pretty much. They have very little fat reserve, so they're at extremely high risk for cold stress and hypoglycemia. They might have had chronic low oxygen in utero, increasing risk for asphyxia at birth, and something called polycythemia.
Polycythemia, too many red blood cells.
Yeah, the body might make extra red cells to compensate for chronic low oxygen, but that makes the blood thicker, harder to circulate, and provides more cells to break down later, worsening potential jaundice. So SGA babies face a tough start.
Okay, flip side. Large for gestational age, LGA 90th percentile or above, often linked to moms with diabetes.
Often, yes, though genetics can play a role too. For LGA babies, the immediate concern is often birth trauma. Being so big makes delivery harder, increasing risk for things like a fractured clavicle or humerus, or nerve damage like brachial plexus injury if the shoulder gets stuck, shoulder dystocia.
Ouch. And metabolically.
Hypoglycemia is a major risk. If mom had high blood sugar, the baby ramped up its own insulin production. After birth, that maternal sugar supply is cut off, but the baby's high insulin levels persist for a while, causing their blood sugar to crash. So close glucose monitoring is essential. They also share the risks of polycythemia and hyperbilirubinemia with SGA babies.
We also need to touch on babies experiencing neonatal substance withdrawal, or NSW. That sounds incredibly complex.
It is. Exposure to substances in utero affects multiple systems: central nervous system, digestion, breathing. These babies are often irritable, jittery, have a high-pitched cry, might have feeding difficulties, vomiting, or even seizures. They're also often born smaller, maybe with intrauterine growth restriction, IUGR.
So nursing care is focused on managing those symptoms.
Very much so. The goal is to provide a low-stimulation environment, quiet, dim lighting. Supportive care includes managing feeding issues, perhaps IV fluids. Sometimes medication like morphine or methadone might be needed to gently wean them and control the withdrawal symptoms. Evaluating breastfeeding safety is also case by case depending on the substance and maternal status.
Okay, perhaps the most vulnerable group facing this transition is the premature infant born before 37 weeks. Their challenge is fundamental, immature organ systems.
Exactly. They haven't finished baking, so to speak. They have virtually no brown fat, making thermoregulation a huge struggle requiring incubators. Their suck-swallow-breathe coordination needed for feeding might not develop until 32 or 34 weeks gestation.
So feeding is a major hurdle.
a major hurdle. And their blood vessels, especially in the brain, are incredibly fragile, putting them at high risk for bleeding, known as intraventricular hemorrhage or IVH.
And this overall immaturity leads directly to the classic problem of prematurity. Respiratory distress syndrome, RDS.
RDS is the textbook consequence of underdeveloped lungs. The core issue is insufficient surfactant production. Without it, those tiny alveoli collapse every time the baby breathes out. That's called atelectasis. The lungs become stiff and non-compliant.
What are the immediate signs that scream RDS?
You see the struggle, tachypnea, breathing really fast, over 60 breaths a minute. You see nasal flaring as they try to pull in more air, retractions, the skin visibly pulling in between the ribs or under the breastbone with each breath, and expiratory grunting.
Grunting, what does that sound like?
It's an audible sound on exhale. The baby is partially closing their glottis, trying to trap air in the lungs to keep the alveoli from collapsing. It's a sign of significant distress. If it progresses, you'll see cyanosis, that bluish tinge to the skin.
And even with treatment, there are related breathing problems.
Yes, apnea of prematurity is common, where they just stop breathing for periods longer than 20 seconds. This often needs treatment, sometimes with caffeine citrate to stimulate breathing.
Caffeine, really?
Yep, it works as a respiratory stimulant in preemies. They're also more likely to have a patent ductus arteriosus, PDA. That fetal shunt fails to close properly, partly because the usual signals aren't as strong in preemies. This lets extra blood flow into the lungs, making breathing even harder.
So care for RDS is intensive support.
Absolutely. Continuous monitoring of heart rate, respiratory rate, oxygen saturation, frequent blood gas analysis to check oxygen levels and acidosis. And often, immediate respiratory support is needed, ranging from CPAP, continuous positive airway pressure to keep airways open, all the way to mechanical ventilation if they can't breathe effectively on their own. #outro.
So, wrapping this up, what's the big takeaway from this deep dive? It seems like the newborn transition is this incredibly synchronized, high-stakes overhaul of everything all at once.
That's a perfect way to put it. It's a rapid-fire cascade relying on really complex feedback loops. And that metabolic triangle, hypothermia, hypoxia, hypoglycemia, really sits at the heart of it.
Right. That connection seems key.
It's the unifying theme. Whether you're caring for an SGA baby, an LGA baby, a preemie, or even a healthy-term infant, the continuous vigilant monitoring of temperature, breathing, and glucose is paramount. Fixing an imbalance in one often helps stabilize the whole system.
Okay, for a final thought for you to consider, think about those specific, very short timelines for the fetal shunts closing. The foramen oval, often within hours. The ductus arteriosus functionally closed maybe within a day or so.
That tiny window, really the first 24 hours, dictates the entire rerouting of the baby's circulation. It sets the stage for independent life outside the womb. What happens physiologically in those first few hours is just monumental.
Truly amazing. Thank you for joining us for this deep dive into the incredible journey of the newborn transition.
It was fascinating to discuss.
We'll catch you on the next deep dive.